Good morning, everyone. Thank you, sir, for the kind introduction. Amazing job by the organizing team. At 9 o'clock, you find so many people in the audience. It's reassuring and shows the work of the team behind it. Next 10 to 15 minutes, I'll be talking very briefly about mediastinal nodes as regards to their anatomy predominantly, not much of pathology. We start with a question. So most of you must have joined, or those who haven't joined, please scan this and join the Slido app for an on-time, a real-time question and answer session. Do I press the next? So the question goes like this: which of the following systems is not used or has not been used predominantly for classification of mediastinal lymph nodes in lung cancer treatment? Is it the IASLC? Is it the Naruke map? Is it the Mountain Wrestler classification or the modification of the American Thoracic Society? Or the Rouvier's classification system? Which is the best match? Which has not been used? Or yeah, that's the correct answer. The first three have been predominantly used in the last 3 to 4 decades, though Rouvier in 1834 was the pioneer who prepared a map of the entire lymph node system in the body, especially so in the neck and the mediastinal lymph nodes. And that's a good job for most of you to start the day with. I think that's a pretty good job. So the organizer is in the leaderboard. Yeah, good. So coming to the classification system according to the IASLC, the 2009, which is in vogue for lung cancer staging. So we got 14 groups which have been 14 nodal stations which have been grouped into 7 zones, starting from the supraclavicular to the upper zone of the superior mediastinal, including the paratracheal and the prevascular group. The aortopulmonary window, both the subaortic and the para-aortic. You have in the subcarinal zone. Then you have lymph nodes in the paraesophageal and the pulmonary ligament. Then you have lymph nodes going from the hilum towards the periphery of the lungs. Now coming to station 1, which is the lower supraclavicular, lower cervical, supraclavicular, or the sternal notch nodes. These are predominantly located. The superior-most margin is the cricoid cartilage in the neck, and the inferior border is the clavicles and the upper border of the manubrium. And the midline, there's got both right and left group of lymph nodes. So the line dividing between the right and left is the midline of the trachea. That's important to know. So for practical purposes, we take the first strip, the thoracic inlet, as the dividing line between the station 1 and the station 2. That's important. We'll come to that a bit later. Now, station 2 is the upper paratracheal lymph nodes. Again, you got the right and left. Now, one very important thing dividing between the right and left is that it's not the mid-tracheal like what you have seen above in the previous station. It is the lateral border, left lateral border of the trachea, which divides the right paratracheal from the left paratracheal. The superior-most border is the apex of the lung, and inferiorly it is bordered by the inferior border of where the innominate vein joins or bisects the trachea. That's the inferior border. So you got the 2R on the right and 2L on the left. So in the axial section, this is anything to the right of the left lateral wall of the trachea is the right paratracheal, and to the left is the left paratracheal. Now coming to station 3, which are the prevascular nodes, which are anteriorly located behind the posterior border of the sternum, and superiorly they bordered by the apex of the lung, and inferiorly they extend up to the carina. So anteriorly are the prevascular, on the left side they're bordered posteriorly by the carotid artery, and on the right side by the SVC, and the retrotracheal nodes are posterior to the trachea. They extend from the apex of the lung to the level of the carina, the 3A and the 3P. Coming to the lower paratracheal lymph nodes, superiorly it's the junction of the innominate vein to the trachea, and inferiorly would be the lower border of the azygous vein. So between that is the right lower paratracheal, which is the 4R, and on the left side, again it's the left lateral border of the trachea. To the left of it would be the lower left paratracheal 4L. Now station 5 and 6 are adjacent to the aorta. So anything which is below the aortic arch and above the level of the left border, upper margin of the left superior pulmonary artery would be the station 5, also called as the aorticopulmonary group. And above that would be the para-aortic nodes, which are anterior and lateral to the aortic arch. So the para-aortic nodes would be between the upper border of the aortic arch and the lower border of the aortic arch. So 5 would be between the lower border of the aortic arch and the upper border of the left pulmonary artery. Station 7 are the subcarinal nodes. The upper border would be the carina, and on the right side, the inferior border would be the inferior-most margin of the bronchus intermedius, whereas on the left side, it would be the superior margin of the origin of the left lower lobe bronchus. So anything in this particular location would be the subcarinal lymph nodes. The station 8 would be the paraesophageal nodes. The superior margin would be the inferior margin of station 7. On the right side, it would be the upper border of the bronchus, low border of the bronchus intermedius, and on the left side would be the upper border of the left lower lobe bronchus, and they extend from superiorly from this level to the level of the diaphragm. Now again, they could be right or left, 8R and 8L. Station 9 is the pulmonary ligament. The superior border would be the inferior pulmonary vein. Now pulmonary ligament is a pleural reflection of the parietal and the visceral pleura onto the mediastinum, extending from hilum to the diaphragm. So anything here would be the pulmonary ligament node, which is station 9, and inferiorly they extend up to the diaphragm. So anything from inferior pulmonary vein to the diaphragm would be the pulmonary ligament node or the station 9. Now station 10 are hilar nodes, which are in close proximity to the main stem bronchi. So you have 10R on the right, 10L on the left. Now superiorly they extend from the lower rim of the azygous vein on the right side to the level of the bronchial bifurcation here, and on the left would be the upper rim of the left pulmonary artery, and they extend up to the interlobar regions. Station 11 would be interlobar nodes. Now on the right there are two divisions, right superior and right inferior. Right superior would be from the upper lobe bronchus to the level of the bronchus intermedius, and the inferior would be between the middle lobe bronchus and the lower lobe bronchus. Whereas on the left it will be between the upper lobe bronchus and the lower lobe bronchus. Now station 12, 13 and 14 are slightly difficult to image at CT or other modalities unless you look carefully at them. Most often they are made out at pathological sampling and post-operative specimen examinations. So you got the 12, which are the lobar lymph nodes, which are adjacent to the lobar bronchi. Have the 13 segmental nodes adjacent to the segmental bronchi, and subsegmental nodes adjacent to the subsegmental bronchi. Now there are certain ambiguities in grouping of the IASLC system. Now supraclavicular versus upper paratracheal in the system. In the supraclavicular group, the lower border is said to be upper border of the manubrium sterni, the clavicles, and the posterior costo-vertebral junction. But if you see a Sassel section, this would be the manubrium upper border, whereas for the upper paratracheal, it is said that it's the apex of the lung. So potentially a node here could be mistakenly classified as supraclavicular or upper paratracheal, potentially changing the staging from an N2 to an N3. So for that purposes, a thoracic inlet has been taken for a practical reason as the differentiation from the supraclavicular to the paratracheal region, which would be the border of the first rib. So anything above the first rib border would be a supraclavicular or a sternal notch node, whereas anything inferior would be a upper paratracheal. Then there could also be ambiguities in differentiating from the lower paratracheal to the hilar node. So if you see that very close space between the right hilum and the right lower paratracheal, and you have a potential space in the at the level of the tracheal bifurcation. But for all practical purposes, a node in this particular location should be taken as a paratracheal node than a hilar node for staging purposes. All surgeons would include that as a paratracheal or mediastinal node than a hilar node. Now, the other thing would be ipsilateral versus contralateral mediastinal group. You have seen the right paratracheal versus left paratracheal. It is to be taken as the left lateral wall of the trachea, not the midline. But the system also does not differentiate the right versus left for prevascular, retrotracheal, and paraesophageal lymph nodes. But for practical purposes, the midline of trachea can be used to differentiate for prevascular right and left, and midline esophagus for differentiating between the right and left, the 8R and 8L groups. And retrotracheal nodes are most often to the right, because on the left side there's the esophagus. So most often they would be towards the right, and they should be taken as a right paratracheal region. Now, distinguishing among pulmonary lymph nodes, as I said, is difficult. It's clinically important, but may not really be clinically relevant when you're trying to image, and they're really challenging at imaging to be able to identify them preoperatively. Now, there are also other nodes which have not been mentioned in the IASLC or other groups, the miscellaneous groups. So we have internal mammary lymph nodes, which are adjacent to the internal mammary arteries here, internal mammary vessels, artery and vessels, veins here. There could also be nodes in the diaphragm along the anterior diaphragmatic group at the level of the cardiophrenic angle, and middle diaphragmatic group adjacent to the inferior vena cava. There could also be nodes along the intercostal spaces, the intercostal nodes. So these nodes, if they are involved in any particular pathology, especially in lung cancer, should be considered as a metastatic disease than a nodal disease. And the lower diaphragmatic and IVC nodes are most often seen in patients with, very commonly seen in patients with cirrhosis. So the next question, any of you who haven't scanned the code, you could do that and start answering. An image-based question. Automatic. It automatically goes. Yeah, the question goes like this. There are 4 sets of images, 1, 2A and 2B, 3 and 4A and 4B. Which of the following is unlikely to be a granulomatous pathology? All of them have lymph nodes in association with a lung disease as well, the last section.
So you have 2 more minutes.
Yeah, sure. It's a split poll. Yeah, congratulations to the, again, so I'll just go through this. It's not moving. The first one shows calcified lymph nodes, hyperdense consolidations with calcifications. That was the case of silicosis, again showing a granulomatous pathology. The second one shows extremely hypervascular lymph node in the prevascular space, very unusual for a granulomatous pathology. That is very classical for a disease called as a lymphoproliferative Castleman's disease, which is a lymphoproliferative disorder. The third is central necrosis in mediastinal nodes, very classical for tuberculosis. And fourth is lymph nodes with perilymphatic nodules, very classical for sarcoidosis. So lymph node morphology, I would skip that for want of time. You take the morphology for size, shape, density, and enhancement as criteria for abnormality that we will be seeing in other lectures or in some other platform maybe. And this is the reference for this lecture. You could go through this, which has imaging maps as well. Sincere acknowledgement to the pulmonology team and the organizing team for having me here. And we work very closely with the pulmonology team, and I learn a lot every day from them. Sincere thanks to the entire team. And of course, the management of Yashoda for having provided such a fantastic work environment and this auditorium as well. Thank you very much.